Ladies and gentlemen, welcome to the Novartis Foundation AI for Healthy Cities dialogue event here on Novartis campus in Basel. I bid you a warm welcome. Thank you for showing up. Thank you for coming. My name is Max Rein. I lead communications for the Novartis Foundation, and I'm delighted to kick us off for an afternoon of thought-provoking and insightful discussions about how cities can translate data insights into action to tackle heart health inequities and cardiovascular disease. The conversations that we're about to have today are inspired by the Novartis Foundation's work in population health and predominantly our program AI for Healthy Cities. Allow me to run you through the agenda really quick. We're going to start with welcome remarks by Dr. Ann Aerts, head of the Novartis Foundation, followed by an opening of Dr. Lukas Engelberger, executive director of the Public Health Department of the Canton of Basel, Stadt, and member of the Canton government, who we're delighted to have with us today. Welcome. We will then dive into a super interesting best practice example from Finland. Juha Jolkkonen, Executive Director of Social Services, Healthcare and Rescue Services in Helsinki, is going to share how data harmonization and availability can elevate health system performance. So thank you for being with us, Juha. Then our very own Peter Speyer, Head of Data Analytics and AI at the Novartis Foundation, will be joined by 5 members of our distinguished AI for Healthy Cities Global Expert Council to discuss the urgency of understanding the underlying drivers of heart health and disparities in cardiovascular outcomes. Our last agenda point will focus on the importance of translating those data insights into actual policy, because research for the sake of research is not going to alleviate the global burden of cardiovascular disease. And for this discussion, moderated by Ann Aerts, we're delighted to welcome Michelle Williams, Joan and Julius Jacobson Professor of Epidemiology and Public Health at Harvard T.H. Chan School of Public Health, and Srinath Reddy, past president of the Public Health Foundation in India. So welcome, thank you for being with us today. As you can see, our agenda is pretty packed, so I'm going to leave you to it shortly. However, allow me to share a few housekeeping items before we dive right in. First of all, this event is going to be recorded, and we will share it later publicly, for example, on our LinkedIn channel of the Novartis Foundation. And I would not be a good communications person if I were to miss the opportunity to invite you to follow us online. Secondly, I saw that we have media representatives with us today in the audience, and I invite you to connect with me after the event in case you have any follow-up questions. And then lastly, perhaps most importantly, we have arranged for a small apéro after our event right outside this auditorium, and we invite you to join us there. I think this is going to make for the perfect opportunity for us to mix and mingle and discuss what we learned today over a glass of wine or maybe 2. So that's it from me. Once again, thank you for joining us today. And yeah, I'm handing over to Ann Aerts, head of the Novartis Foundation.
Thank you so much, Max, for the great introduction, and also from my side, in the name of the Novartis Foundation, a very warm welcome to our campus here in Basel for what promises to become a really inspiring dialogue on AI for healthy cities. And why are we hosting this here in Basel? Well, you know that over the last decennia, we have seen these enormous scientific breakthroughs in medicine that have extended our life expectancy by tens of years, and mainly thanks to the improvement of cardiovascular medicine. And the cardiologists in the room will agree with me, I'm sure. At the same time, over the last decennium, we have seen a convergence with also the innovations in technology, which allow us now to change the way we deliver health and care and make health services available to where and when people need it, even in their living room or on a remote island in the Philippines. So that convergence has really changed the way we look at our health systems, but still we need to go a step further. We need to make use of the opportunity of living in this era where we have a massive amount of data, great computational power and data science capabilities to leverage data and artificial intelligence to better understand still what drives our health, and specifically what drives these rising health inequities. Because even with these scientific breakthroughs, with the technology innovations, we see that, for example, cardiovascular disease is still the #1 killer in the world, responsible for 1 in 3 deaths, millions of people living in disability or losing their lives due to cardiovascular disease. And at the same time, a baby born in one area of the city of New York with a certain zip code has 12 years difference in life expectancy than a baby born in the neighboring zip code. How come? We need to challenge that reality. And that is exactly why we are discussing AI for healthy cities. It's exactly the reason why the Novartis Foundation set out to start this ambitious initiative, where we bring together hand in hand with the city authorities of 5 data-rich environments. And these are the cities of Basel, Helsinki, Singapore, Lisbon, and New York. And you will hear about some of them today. We work together to bring the data from the health sector in the same place with the data from the health influencing sectors, so that we can better understand what truly drives health and health inequities. Because in the end, we know that only 20% of our health is determined by the health care we access. All the rest is determined by the conditions in which we live, the food we eat, the pollution in the air, the social connections we have, the income, the economic status in which we live, or the city area we live in, the physical activity, and the digital access, as well as our education. All of these factors are much more important than the health care we access, and maybe the reason why we still see these enormous inequities in life expectancies, why we still see the cardiovascular diseases not performing better, because the medical services are there. And this is what AI for Healthy Cities has set out to do, to understand what is it, 80%, what in this 80% exactly do we need to change to make sure that we can reduce this cardiovascular mortality, that we can reduce the health inequities. And that's what we are going to discuss today. So join me in welcoming our welcoming speaker. It's Lukas Engelberger, the Executive Director of the Public Health Department in Basel, Stadt. We are thrilled to have you with us, Lukas. Please, the floor is yours.
Thank you very much. Good afternoon, ladies and gentlemen, dear board and team members of the Novartis Foundation, dear Ann, dear members of the AI for Healthy Cities Global Expert Council, dear speakers, honored guests, ladies and gentlemen. First of all, I would like to welcome all of you to Basel. It's a great pleasure for me to do so. If this is your first time visit to Basel, if you haven't heard about Basel before, don't be ashamed. We are small. In fact, we are the smallest canton in an already small country. Switzerland has 26 cantons, and we are one of them, the smallest one in terms of geography, let's say. And we are a not so big city as well, and for practical reasons, our cantonal government is in the same time the municipal government for the city of Basel. So that's something I think, constitutionally speaking, that is special for us. And another special thing about this small city is our ambition to be big in science and in pharma. Well, I'm talking about this later on. But before, I also want to mention the special situation in which we are located geographically, so close to our neighbors in Germany and in France. From right here on a bicycle, you can visit 3 countries in 10 minutes or 15 minutes. It's really easy, it's really close, it's really convenient, and it's normal for everyday life here in our region. I would like to thank the Novartis Foundation for bringing this initiative to Basel, and I do so in the name of our Executive Council. Bringing this initiative to Basel, the place where the predecessor companies of today's Novartis were founded over 150 years ago, and where the company is still headquartered and very active today. We are proud of this company. The city of Basel is primarily known as one of the most important locations for the pharmaceutical industry. It is a bit less well known that Basel holds the oldest university in Switzerland, and that many health innovations have their origins here. Accordingly, the University of Basel is one of the most important cornerstones of our life science location and tradition. It was founded in 1460, so that's even before we became a part of the Swiss Confederation, and has had a medical faculty ever since. Many scientists who were important to the world of medicine have researched and taught at the University of Basel, including famous physician and alchemist Paracelsus and 10 Nobel Prize winners. What would Paracelsus have said over 500 years ago if he had heard the title of our meeting today? First of all, probably, what is artificial intelligence? Then he might have guessed whether this would be some new concept in contemporary theology, maybe. For us modern people, of course, the world is totally different. AI has become a familiar term within a very short time, and it is associated with great expectations, not least in the healthcare sector. However, great expectations often harbor great challenges. This makes it important to pool expertise and to work together in interdisciplinary teams in demanding areas such as AI. And this is exactly what the Novartis Foundation is doing with its AI for Healthy Cities initiatives. They team up with researchers in different cities all over the globe to link and analyze various existing health data. The ultimate goal is to improve cardiovascular health of the population. I am very grateful to Novartis for being even more than an extremely innovative and successful pharmaceutical company. Novartis is also a charitable and a socially committed company. And so I would like to thank the Novartis Foundation for its great commitment. It pursues a goal that is one of the most fundamental goals in healthcare, to create greater health equity for as many people as possible. This is most relevant in all countries of the world. You made that point before very clearly, and the same is true for Basel. Also for Basel, there are maps laying out this difference in life expectancy, depending on whether you are happy to be born in a wealthy area or not so happy to be born in another area. Unfortunately, this is proven even for our quite rich city here. I am proud and thankful that the AI for Healthy Cities project is now also being implemented in Basel. This type of project is a first for us. Research and industry are joining forces to provide findings to us in the public administration that we can use to directly benefit our cantonal population. Now, let me say a few words about the Basel AI for Healthy Cities project, which focuses on identifying factors influencing childhood obesity. In Basel, we are fortunate to have not only an excellent university, but also equally excellent university hospitals in the field both of adult and pediatric medicine. The team led by Professor Julia Bielitzky, she's going to talk to you afterwards at the University Children's Hospital in Basel, will identify, process and analyze existing data on their young patients with the support of the Novartis Foundation. we highly appreciate that we, as the Department of Public Health of our cantonal administration, that we have the privilege to be part of the project group in an advisory and supporting role. Our aim as healthcare planners and providers is, of course, for the findings to provide additional information on obese children in Basel and on possible preventive measures, of course. For the Novartis Foundation team and their partners, however, the journey is maybe already the reward, and at least to a certain extent. As part of the project, they can build up experience, we can build up experience with various stakeholders on how to make best use of large routine data sets. This development of expertise and a specialized network can also be useful for future endeavors, and so the AI for Healthy Cities project may open up new opportunities to explore connections in other health topics as well. Ladies and gentlemen, progressive and innovative initiatives such as the AI for Healthy Cities show that medicine and life sciences not only have a long history in Basel, but also an extremely lively present. I completely agree with the Novartis Foundation when it says that the ultimate goal is for a paradigm shift to take place from health care to health, from a reactive system to a proactive, predictive and preventive system that keeps people healthy. We have come very far in medicine in the last few decades, in the last few years alone. Much further than even one of the brightest medical minds like Paracelsus could have ever predicted. I wish the Novartis Foundation and all those involved in the initiative every success with their endeavors. I would like to leave the researchers with a quote again from Paracelsus. Half a millennium ago, he said, "All that we need for health and healing has been provided by God in nature. The challenge of science is to find it." Well, I think the challenge remains, but AI and the projects of the initiative that we are being part here all together will help to tackle the challenge. I wish you all the best in the great work that is being performed under the umbrella of the Novartis Foundation. Thank you for hosting us today.
Thank you very much, Lukas, for the beautiful speech. And you said what I forgot to say, why we host this in Basel, because Basel is a hub for innovation, scientific innovation and technology innovation. And maybe some of the startups in health tech are here in the room. So this is exactly the reason why we are together here. So it's now my pleasure and honor to introduce Juha. Juha Jolkkonen is the Executive Director of the Social Services, Healthcare and Rescue Services of Helsinki City. And you will give us a keynote on how data harmonization and integration can be used to make better decisions in health. So we look forward to your talk, Juha.
Good afternoon, ladies and gentlemen. It's my honor to be here and tell you briefly some insights from Helsinki as I would say a case kind of an aspect. I'm not going to tell you about data and AI itself that much, but I'm going to tell you something about our service system, how we get the data, how we use the data when it comes to services, and how we build the basis in the system to get the data and use it in the future. So my background is I'm a doctor from my background, but I have been in leadership positions for many years now in Helsinki and in metropolitan area in southern parts of Finland. I used to work for Novartis Pharma also a couple of years, but that has nothing to do with why I'm here. It's just some a few years from my background, very good years though, but still. Just a few words about Helsinki. We are responsible, as I said, for the social care, health services, and also rescue services for all the inhabitants. Around 660,000 should be there, Helsinki inhabitants. We also provide services ourselves. We procure services from hundreds of service providers. And of course, we do have specialized healthcare in the hospital district. We own the hospital district together with all the other areas in southern part of Finland. Some numbers, we have 16,000 employees, and we spend approximately 2.9 billion euros a year taxpayers' money. We are the only city responsible for the services at the moment. In Finland, we had a major reform of social and healthcare and rescue services about a year ago, where in other parts of Finland there are well-being areas or well-being counties between the government and the municipalities where these services are. But Helsinki is the only city still responsible for the services. And this picture is important when it comes to the topic today. We in the city have a unique possibility to tackle the questions Ann just mentioned when it comes to different kinds of aspects of health and well-being. Because health sector or health services can't really do much. The other actors, the other stakeholders, the other services are in bigger role. But the difference is that my division is funded by the government, and the other part of the city is funded by the municipality. The funding differs in our system, so there is a sort of a line here when it comes to funding. But still, we lead the city as one unity. And that's why it's possible for us to set, for instance, common targets, common goals for health and well-being. And that's important when it comes to data, when we find out we should do something, for instance, in one area or with some subgroup of people, then we can together jointly find the targets and find the interventions. This is, I know, a tricky picture. I just wanted to have it here because there is a classification, I think, everywhere, but also in Finland from the Finnish Institute for Health and Welfare. They want to classify the remote services in health and social care. I will come to some of these later on, but we try to sort of classify the remote services. There should be the core system or the core unity, health and social record, of course, but then we have remote contacts, remote transactions, of course, different kinds of digital services, and I will come to this a bit later, but this is just not an architecture picture, but still you get a brief, quick look at what this is all about. The 20/80 ratio is also useful here. We know that 10 to 20% of health and social clients are those ones that need multiple services, or they have multiple risks, or they might need multiple service providers. And they actually spend around 80% of our funding. So that's why it's important to focus also on these clients and these customers. These are, of course, VIP clients for us in social and healthcare. Of course, we take care of the rest of those people, the 80% that don't use that much service. But these are the critical ones. And when we coordinate, when we integrate the services of these people, we can have better quality and cost savings. That's the whole idea. And integration, a few words about integration. Of course, it should mean for the customer or for the client, it should mean a service process, a path that would be easy, clear, as straightforward as possible, no matter what kind of question or issue or problem you would have. Of course, as often as possible, it should be, the contact should be done electronically or maybe without any professional needed at all. when it comes to, for instance, algorithms that can guide, that can give help to a client. But of course, when a professional is needed, we should guide and get the client to the right person at the first time. And of course, we need cross-sectional services and cross-sectional teams. And we have health and well-being centers where we have gathered many different services. We have multidisciplinary teams. And then, of course, we need some support services for these ones. I can continue with this. Of course, we also need to integrate data. And that I can come to our basic or the core system. We have had a core system that's based on EPIC, the American, widely used healthcare system. But we have built our own system called Apotti, based on EPIC, but it includes all healthcare, specialized care and primary care and all social care. So I think it's, at least at the moment, the only system that includes all social and healthcare data and services and service paths. And we use it in Helsinki. One of our neighbor areas use it, and the whole hospital district, Helsinki University Hospital, uses it. So basically, we do have all the service paths and all the data in the same system. And you might know, whoever knows EPIC, that EPIC has no boundaries inside the system. Well, we do have some legal boundaries, so we have had to build some walls inside the system. But basically, if we can crash the walls legally in some point, we do have all the data there. And we have all the data in the same system. We can use it, whatever is legal, we can use it on a population level or on an individual level to see what's happening, how do they use health services, specialized care or primary care or social services, and what is the connection, what is the correlation, for instance, between these ones. And it's also a unique database when it comes to today's topic. We can, at least in study settings, use this customer or client database and combine the information, at least on a study setting and population level, to any other databases or indicators we're going to get from the same people or from the inhabitants from the city. So this is a unique opportunity for us, and I think we will gain for it in the future. We have been using the system for about 3 years now. We have information from about 1 million patient or clients at the moment, but of course it's increasing all the time. On top of that, this is our own system, the core system. Of course, we use EPIC's MyChart, which is the patient and client portal. It's one app, one application that includes all social and healthcare visits and contacts and the use, how the client or the patient can use e-services via just one app, because we don't believe in several apps or different channels people need to contact. You need to have one channel where you can deal with all your contacts and all your issues when it comes to social and healthcare. And then the third level is actually national registries, Kanta registries, which mean when you translate it to English, it's you could say base in English. But I think I already mentioned these ones, and as I told you about Apotti, it makes it possible for us to do many things inside the system within the professionals. About 45,000 professionals use Apotti at the moment. And of course, when it comes to specialized care, 1.7 million inhabitants can use the MISA portal, for instance, or in the city of Helsinki, 660,000 people. So we're going to gain a lot of data. But of course, we do have some challenges. We have been discussing quite a lot about these challenges, for instance, within this initiative we're going on. Implementation, of course, when you integrate services, it's not easy. Professionals are not very used to work in multidisciplinary teams. If it's new to them, it takes some years, some training, some mind-setting change if they need to, or if we want them to work together, more together than before. The GDPR in Europe, in EU, and also our own legislation is very difficult when it comes to data, when it comes to the use of data and combining of data. And this is something we struggle all the time. For instance, we have combined services with social and healthcare. We have combined the IT system and the data, but legally, social care people and healthcare people are still different. And that's a bit of a problem. But we're going to move that away in a few years, I believe. A few words about digitality. Of course, we also provide digital help and digital services not only to treat problems or issues that arise. We also use them for preventive use. So people can have contact to us. They can take advantage, for instance, coaching that can be developed or can be they can have electronically, and we encourage people to contact mainly via e-services. Of course, that's not always need to have other channels. You can always have a phone call, you can always walk in, but actually majority of people want to use e-services if they are available, if they work, if they satisfy their needs. Of course, I think 70 to 80% of people want to use e-services if we can provide usable e-services for them. They're very happy with services you can use 24/7 wherever you are. And of course, it allows us to build some automation, robotics, artificial intelligence on top of that when we create the basis of these services. So that's where we can use them. Just an example, sorry, they are in Finnish, but you can see the well-being counties, and the city of Helsinki is, of course, the first one. We lead the way in e-service usage, so more than 50% of our customers and clients are using also or mainly e-services. Actually, our national goal has been 35% till 2025. I think it's way too low. It should be 75 or 80%. But we're moving towards that. So that's why I like to talk about e-services, because they are very important when you speak about data or when you speak about algorithms or the use of AI in the services themselves. Some of our digital solutions, I already mentioned the MISA, the patient or client portal. The other one that we use is a symptom checker device or symptom checker service. This is a national service. The Oma Olo service is a national service that we have integrated in the MISA portal. And there we have, I think at the moment, 16 symptom checkers that people can do themselves. And if needed, that guides them to a professional, not always needed. Of course, we can have RPA solutions at the moment and in the future more than now, and chatbot, that's also very popular, for instance, with families with small children. Chatbot usually gives them answers in 90 plus something %. So it's very popular. And some figures about the usage. We had, for instance, last year, the first 10 months, we had 18 million sessions in MISA portal. So it's really widely used and very well accepted. We had more than 80,000 symptom checks in the first 9 months last year. And third example, with chatbot, just in October, almost 8,000 answers or contacts or discussions. So this really matters. This is not something, some high tech or some lunatics that someone want to use these kind of services and that doesn't cover all the population. It needs to be the basic service. The e-service needs to be the basic service for almost everyone. One example of how we use data, not enough yet, but how we try to use data is the health benefit analysis. We try to use within our system where we have data from about 1 million patients and clients. We use this kind of a decision support tool that is based on evidence-based medicine. We use it to dig out from the data those possible care gaps that people themselves don't know yet. So we would like to contact them. At the moment, it's not legal in Finland. So if the people, if the person hasn't consented us to contact him or her, it's not legal at the moment. But still, we have the capability. We can do it on a population level, for instance, in subgroups or different areas in the city. But on an individual level, it's not allowed to use it. Not yet. Well, I won't go through these, but these are just some examples. I think you will get the material later on. These are just some examples. Just a few words about current examples. These are just some developments. I already told you about the health benefit analysis. We do have some health monitoring digital models. As I told you, when you build the basis, then you can build up many kinds of new services and new approaches. Pre-appointment smart questionnaires, not dummy questionnaires only, but smart questionnaires. Medicubex is a e-health station. You can go into a box and the box measures your blood pressure, your saturation, your body composition and these kind of things, and they go directly to our electronic record and are available, for instance, for your physician if needed. It's not always needed, but if needed. And also the other one, the QMEA, is a new kind of a tool to survey, for instance, elderly people living at home. It's a small device you put on the ceiling, and it's very sensitive tracking on your movements or fall, or if you're not moving at all, and it gives directly to a call center your information. These are just a few examples, but you can't use these if you don't have the core system fixed. And of course we need, these are technical aspects, but we need interoperability kind of issues tackled, because we have a lot of devices, a lot of applications. The world is full of different kinds of technical solutions, but there are no use of them if they are not integrated and operable with the service system. Of course, as I told you, we can have predictive models from the electronic records, and this is a very important in the future is to see also the national level data from the national registries, and this is something that will be developed better. Finland has been very proactive in having this kind of national registry, but the first ones are like PDF documents in a library. It doesn't work very well, but the next generation version should be even better. And in 5 years, I think this is not ambitious enough, but still we need to have modern data platform. We are going to build our own data lake, and we're going to try to combine our data, for instance, with other areas and with the university hospital in some way, no matter what the legal aspects are. Of course, cybersecurity and data protection is crucial, but I think it's evident for everyone. The customer-centric digital services I already mentioned, they're very important. Of course, automation of routine work and processes. When it comes to artificial intelligence, for instance, we should do many things by automating compared to what we do now. And of course, when it comes to prevention and preventive activities, for instance, care gaps, different kinds of predictive models, but that is where we need the data. We need also the data from other cities, maybe the predictive models that we may not identify ourselves, but when we take a look at Singapore or New York or Basel or whatever, we can share the data and insight, and that's how we can also make this richer. This was just a brief introduction to what we do and how we think of the service system data and e-services. Thank you.
Juha. This was a really eye-opening and inspiring talk about how you lead the way in digitizing the health system and making it proactive, predictive, and ultimately preventive. It was really nice to hear also the challenges in becoming proactive. It's not always easy, and we look forward to working with you and delivering these answers with, hopefully, with AI for Healthy Cities of what drives better outcomes. So now it's my huge pleasure to invite our panelists on the floor, David, Spring, Julia, and Peter. Peter is our head of data and analytics at the Novartis Foundation, and he will be the moderator of this panel discussion on how urgent it is to better understand the drivers of population health and health inequity. And Juha, of course, I had to leave you here on.
So welcome everybody. Thank you for joining us. Thank you for taking time out of the beautiful weather outside, joining us here in the basement and listening to what's hopefully going to be a very exciting discussion about the underlying drivers of cardiovascular health outcomes and health equity. I am actually very excited to be joined by a very diverse panel of collaborators and expert council members who are providing invaluable advice to the Novartis Foundation and the AI for Healthy Cities projects, but that will now provide insights on these drivers of disease. I am joined next to me by Spring Gombe, who's strategic advisor in global health policy. Next to her, Juha, who you heard from and who was introduced. Then Julia Bielitsky, who is the head of the Pediatric Research Center at UKBB, the University Children's Hospital here in Basel. And then David Napier, professor of medical anthropology at University College London. Before we jump into the discussion, I just wanted to briefly set the scene, kind of what are underlying drivers. So cardiovascular disease is to a large extent preventable. And this prevention depends on addressing drivers which cause or progress heart disease. And for the AI for Healthy Cities initiative, we're thinking about these determinants in 4 buckets. The first one is what we call givens. Those are things you cannot change, like age, sex, genetic drivers, and the location of a person. The second big bucket are the social determinants of health. Those are the conditions in which we are born, grow up, work, and age. And those include things like the environment around us, the built environment in a city or landscape around us. It includes the social and cultural context which we live in. But last but not least, also education, income, and other economic factors. And these obviously depend a lot on the location and where you live. The third buckets are health behaviors. Often influenced by these social determinants, we still have a somewhat limited, but a range of choices on how we eat, physical activity, alcohol, drug use, and other components. And then the last component is actually the impact, what Juha just described, health and social care that directly affects outcomes. So it's a very rich and diverse set of drivers which all influence each other. And so we'll dig a little deeper into kind of what do we see as the role of these drivers and what can we do to ultimately improve health outcomes and equity. We'll go through kind of 3 thematic blocks, one kind of talking about social determinants, looking at challenges, but also opportunities in using data and technology to improve them, and lastly, kind of a little bit of an outlook on how can we improve the situation with these underlying drivers. We will have some time for Q&A at the end, so take good mental notes, and then we'll have a roaming mic for you to be able to ask questions. So let's kick off and look at the role of social determinants in driving health outcomes, and maybe start with you. David, you're a leader in the Health Inclusivity Index, a lot of work that includes work on social determinants. Can you tell us a little bit what you found in the study and the role that you saw of these drivers in health? Should be on.
Can you hear me? Okay. We've been working with the Economist Impact Unit on the Health Inclusivity Index, which measures health inclusivity currently in 40 countries globally. Now you may say, why are we interested in health inclusivity as opposed to our usual framework of health equality or health equity. And of course, we know that equality is fundamentally giving everyone the same thing. Equity is giving people what they need to have the same outcome. So where does inclusivity and exclusivity come into this? Well, we all know populations are aging, people live longer, less healthily. People find themselves caring for themselves more, and we know this because the reaction of many pharmaceutical companies is to move into the domain of over-the-counter products because simply we do not have the capacity to deal with all the needs of all the people. And of course, in spite of many noble efforts to improve that, the problem is there and it will continue to be there. And if anything, it will potentially result in people living more excluded lives than included lives. And of course, we saw this, especially in COVID-19, where people found themselves fundamentally excluded from much of healthcare and lining up in long lines behind pharmacies, trying to look after themselves. So what this tells us is that we, and this is the second really important thing about this, is that we really need new models. We need new models because already of the 8,000 some hours a year, you may spend 4 or 5 or 6 actually in a clinical care setting, and for the rest of the time we'll be looking after ourselves. We need models because if we have a health inclusivity index and all we do is look at equity and equality, the welfare state countries will always be on top, and the poor countries will always be at the bottom. So how do you take action on health inclusion that actually provides people options that are real to them, other than poor countries being envy of the wealth of wealthier countries, right? How do you define inclusion when some of the most wealthy countries are highly inclusive as it relates to their populations, but also relatively exclusive as it relates to other populations, and indeed the populations they need to do things in their countries that the replacement populations aren't doing or can't do into the future. So it helps us to reframe. What we actually take to be important and what the new models are. And this is where AI becomes especially important. I can say a lot more about this, but just one final point before I pass the microphone. And that is that because people are spending more time on their own, their lives are not controlled by randomized control trials and the effects of smoking on cancer or the effects of green spaces on obesity. Those are all very, very important things, but we all know that our lives are characterized by compounding risk factors. Compounding. So to eliminate the compounding effects is in effect not to be able to bring our lived experience to the level of evidence. So we need new kinds of methods for looking at this, and this is something that AI can help us from the standpoint, from modeling all the way up to implementation, all the way up to prevention. I'll say a little bit more about that as the conversation proceeds, but I'll stop there.
Thank you, David. Yes, we will dig deeper into the opportunities in data and AI to improve the situation. Julia, as a researcher and clinician in constant contact with individuals, after the global level that David provided for us, how are you looking at social determinants? What do you know? What would you like to know? What is the role that this plays in both research and clinical practice?
So, you're opening a very large pot, but as a clinician, of course, you do worry about the context that your patients move in, and this is something that is particularly strong in pediatrics, where this is also most important because obviously children's lives are very much influenced by the context that they live in, their family structure, their schooling, etc. However, in a sense, I think we're still lacking a lot of the information that we could actually benefit from, because at least in the case of both the UK and Switzerland, where I've worked, we don't have the situation that you has presented, that we can actually access this information in a meaningful way quite quickly. for our patients. So we ask questions, but we ask questions in a very, I guess, deterministic way. You know, we focus on a very specific situation, and so I think we are often lacking the context that we would need. And importantly, I think we are doing our patients and their families a disservice because it's not connected. So it's often information that is gathered by me in a specific clinical interaction, but there isn't actually a sort of place to deposit that information in a meaningful way so that the next person who interacts with that family might use it. And they might not even consider it relevant.
Yeah.
At the time, but you know, they can't access what I have in my brain that isn't really captured in a meaningful way as data. And so I think that is the main challenge that we face. It's not that we aren't aware of their importance, and it's not that we don't attempt to gather information about that, but actually we are very iterative, and it means that we often lack the full picture because we don't have anything to build on from all the interactions that have come before.
Yeah. Yeah, so it's a question of systematically collecting this, right? You have the anecdotal evidence, but
I mean, one of the very typical examples, and we are trying to actually tackle this in one of our other projects, is that we can't access information from primary care providers. And in pediatrics, primary care providers are the most important reference person in terms of healthcare and health and well-being, because we have well-child visits in Switzerland. We're very lucky to have them.
Yep.
There are lots of settings that are not able to provide them. And actually, this is where a lot of the preventive work takes place. But I, as a hospital provider, the only way I can access this is I pick up the phone and I call that pediatrician, which is not a very efficient way, as I'm sure will be very clear to everyone in the room.
Because then you will likely get a PDF with the summary information from the pediatrician.
Yeah, and again, it's the same thing. That pediatrician also does not have a system of capturing all that information. Yep. So whatever they will be relaying to me is very much influenced by the questions I'm asking. It's not actually a picture that is comprehensive, that allows me to actually ask informed questions, build on the knowledge that has been gathered about that particular family and patient before.
Yeah, thank you. So Juha, you were already talking about the integration of social and healthcare, which kind of takes care of some of these aspects. But I would love to hear from you kind of in general, kind of the city perspective on this. So by 2050, 70% of the world's population will live in cities. So I think this is also why we're looking at cities in the AI for Healthy Cities initiative. What's your view on how you kind of solve some of these challenges? How are you looking at social determinants beyond the social care, but also these other drivers like education, like income, and how can you address those in a city government context?
It's a good question. Of course, I do have a mic here. It's a good question. Of course, we have been doing it for years, so we have been trying to do it for years. So we have been looking at health and well-being, or promoting health and well-being on a city level. And for instance, at the moment, we do have identified 6 target areas or target groups of doing mental well-being, hobbies and leisure, physical activity, lifestyle. We call also good relations, meaning social relations, and also relations between subgroups of people and neighborhoods, and safe and beautiful city. So these are the topics we are working on. Of course, they are based on knowledge. They are based on data to some extent. Yeah. But to be honest, they're not very good. The database is not very good. And that's why it's more like this when we come up with these. And this is something that we can do better. We could use data because we do have a lot of data, also from the municipal side, not only from the social and healthcare side. We could use data, we could use AI to dig out the really meaningful targets and really meaningful doing. And of course, we also allocate funding according to these targets. So we allocate funding, for instance, to certain areas in the city. But now we should do it even more based on data, evidence-based kind of approach. And I think it would be easier also to have the funding accepted widely when you have the data and when you have the evidence behind that.
Yeah.
And because we want to do that, it's actually also politically accepted, but now we don't have the real database behind it.
Yeah.
Not enough, at least.
Yeah, exactly. So it's about collecting the data systematically, but then also how do we store it? How do we connect the right databases? And then to your point earlier, how do we use this information? Can we contact people where we see there's something brewing, and then you don't have the right to actually contact them, right?
Yeah,
so
that's true.
I think interesting challenges.
We should be more proactive, of course.
Yes.
Now we take a look at the challenges or the problems that already arise.
Yeah.
We should be more proactive to prevent the problems.
Yeah. So I think you two are very aligned, right, in terms of what you need and what we see as key challenges. Spring, with your experiences in market access and technology deployment in sub-Saharan Africa, I wanted to get your kind of more hands-on perspective in low middle-income countries. It's a slightly different perspective on social determinants, the role they play. Can you elaborate a little bit on kind of how you're looking at the overall framework and the influence that it has on health outcomes?
I'll try.
Yes.
So without wanting to, find two very clear messages for 160 odd countries, there are developments in the global south that I think are very relevant and for which we can leverage AI. The first is that in 6 short years, there will be about 43 megacities in the world, cities of populations of 10 million plus. 36 of those will be in the global south, predominantly in the Asia-Pacific region. That means that the challenge of providing services that are responsive to the needs of children, where they live, of understanding the context and the patterns, etc., will become that much more complex. And if you think about the 10% who need 80% of the services that are provided by a city, that will be 1 million people in each of these cities. So it's really very important to understand what is underpinning their health. In the Asia-Pacific region, one of the opportunities, I'm not supposed to get to that quite yet, but one of the opportunities that is presented is that even though these megacities are very large, they're quite sophisticated. And so there is the opportunity to gather data very rapidly and then to leverage AI to identify patterns where we as humans cannot see them from the disparate places where we all sit. So that is one set of challenges and opportunities. The second is, if you look at my continent, Africa, we have a population whose median age is 19 for the whole continent. And so what does that mean? Age is static, you can't change that. But it is a population that has grown up in conditions, rapidly urbanizing too, but in conditions that are very different than we see in cities here. 30% of children in Africa live in informal settlements. Those informal settlements move all the time. And they are things like cardboard boxes. And so there are no neat zip code analyses that can be done and that from which AI can derive answers, right? So that is one thing. The second thing is, over generations, African populations have not had access to quality hair and certainly not to well baby visits in the same way that you have here in Switzerland. And so we have a very young population, but one that is relatively unhealthy. When you look at mental health crises in the world, there's a global mental health crisis. In the global north, it is attributable to loneliness. In the global south, in Africa, it is very much attributable to very insecure living environments. So these children who are growing up unprotected are already at risk of severe non-communicable disease, morbidity and mortality, some 30 years, 40 years down the line, but don't have the luxury of thinking about what's coming 30 and 40 years down the line, nor do the policymakers who are making decisions for them now and who are making decisions about where to invest money. And so AI can be leveraged to paint that picture very clearly for all aspects of urban planning, decision-making, etc., so that people are cognizant of the need to invest in non-communicable diseases, in preventive care, in anticipatory care, if we are going to lift countries out of, and people out of fragile and vulnerable situations into situations where they can fulfill their potential as human beings.
Yes. Yes, thank you for a very stark reminder and painting that picture for us. And I mean, I think what you just described is kind of this dual burden, right, where we have countries which are still grappling with a large burden in infectious diseases, but at the same time, you cannot ignore a growing non-communicable disease burden. It seems that the data and AI question comes, or opportunity and challenge comes up in the comments immediately, right? I think an important factor that we're all acknowledging in our initiative as well is how do we measure, how do we deal with information? Maybe David, you already started kind of alluding to this. You see these opportunities in leveraging data and AI, right? Maybe go back to this kind of global, looking at the inclusivity index. Like, how would you ideally like to leverage data and AI? Where do you see the opportunities to accelerate improvements?
Yeah, I mean, I think that's thank you very much, second time. I'll remember third time. That's a terrific question, Peter. I think that, it's a question of both seeing the cup half empty and seeing the cup half full. I mean, the half-empty part is if you look at data on the social determinants of health, you look at the Lancet report on health inclusion and so forth, everybody knows that this data is really poor because of the kind of data that we value and how we collect data and the way in which we value data as it relates to the purity of that data, which is predicated on all sorts of research practices that don't necessarily have much to do with how people live on a daily basis, right? We also know that the kind of data that we need is not data that we get easily through focus groups and surveys, because those people who are in states of pure calamity coping don't respond to either of those things. They're just invisible to us. And we know this because you send the survey home in the rucksack of the kid who lives in poverty and it comes back empty, right? So we have to develop different strategies and different ways of going about dealing with this level of social invisibility. And then also, and I say this from the perspective of working for the last decade with cities changing diabetes, is that the tragedy, of course, is that for all, as you mentioned right at the beginning, Peter, these are preventable. So you have half of the people in the world living with diabetes that aren't even diagnosed, right? Showing up when they can't see anymore, or they have, their foot's falling off, or whatever it happens to be, and all of that becomes preventable. So the question of understanding what's happening between those half that aren't diagnosed and those half that aren't in treatment and those half that can't adhere, and so on and so forth. That is to say, those social drivers, if we don't understand those, we end up not only with 20 and 80, we end up with something more like 5 and 95, right? That is to say that the cost of that, not just financially, but also in terms of human suffering, is completely unacceptable. And then there's the part Spring that you just referred to, which is the whole question of stigma and the way in which we assume that it's an individual's responsibility to take care of their health because these non-communicable things are preventable. Therefore, you should be able to prevent them. And the stigma that people live with, for whom the thing that's going to kill them isn't even on their list of concerns that day. Yeah. It's not even 8th, 9th, or 10th. It's if you don't have a diagnosis for diabetes, it's totally a social issue, isn't it? You can't even define it as clinical because it has no clinical. There's no exchange between that person and what we would call the social services that people need. So I think that we have a tremendous opportunity here to make that change. And of course, early diagnosis, or even giving people, homeless people, all have cell phones, right? So why can't we have some level of co-production of knowledge? Citizen science, I mean, people go on about this. There are all sorts of ways we can find out about what the barriers are that prohibit people from being able to have health agency and take actions that actually improve their lives. And sometimes those tipping points are really small things that allow people to emerge from having no agency to having some. I could say a whole lot more, but you got me going there.
I can tell. Maybe just briefly back to Spring, in terms of kind of informing and triggering more policy intervention along the lines of what David described. Like, what can we do? Like, how do we get this change started? How do we share the right information? How do we give policymakers an opportunity to kind of set priorities and help with collecting, analyzing data and setting priorities?
I'll give it a stab. I think let's look at Africa. I'll just focus on that for now. So care is delivered in the context of community health work, right? Often by lay health workers who previously did not have access to resources to collect data in any coherent kind of way. And nowadays they're armed with mobile phones and they have these apps that are sharing data in real time back to the health services, and ministries of health are beginning to pay attention to them, or even ministries of finance, as an important part of the health workforce and as people who need to be compensated and remunerated. And on the other side, they have the trust of the communities in which they work. So it's not a question of trying to improve data literacy and the way in which we clean data everywhere, this everybody everywhere all at once kind of way. I think if we invest in arming community health workers, improving their data literacy, leveraging the trust and the facility that they have with their communities immediately in urban areas, also their ways of negotiating those spaces, then we can jump over quite a few of the barriers to getting to the kind of data that we want. The second thing is taking advantage of the youth of that continent, right? Yeah. I mean, 12-year-olds can do things with mobile phones that we did not know were possible, and they'll just pick up a phone and figure out how this tool can do X, Y, and Z and can improvise in that. So there's great enthusiasm and great hunger for using these tools, and there's an opportunity for all of us to not be so old and cringe and to try and figure out how to communicate with them at the level that they are, that they can actually be the ones who help us understand how to communicate in a way that they're interested in becoming data literate.
Yes, really good points. Thank you, Spring. Juha, when you think about kind of these activities and then take a step back in a city context and thinking through things like education, economic development, and stimulating kind of health improvements across a range of determinants, how are you thinking about this in a Helsinki city context? Can you share a little bit about the conversations going on, like how do we fundamentally improve health across the many determinants?
I know. Well, it has been actually mandatory for years to implement also evaluation of health and well-being effects in all decision-making in the city. Mm-hmm. But it doesn't work well. It doesn't work well enough. People don't do it. The coverage is not good enough. And they're not based on evidence, they're not based on data, they're just descriptions on how things should look like or would look like after this decision. So we need evidence-based evaluation to the decisions. So it's like an evaluation, but it's also a basis for the decision why this is made. Yeah. And of course, it can also make a transition from what we do now. We basically offer the same for all kind of services. Of course, we need universal services in the future also, but we should try to make a transition to more targeted service production also. I don't mean health and social services only, but all the city services. So we need to do risk identification, risk-based focus on the services, on the money and all the personal resources we have. We should target those resources better, risk-based, when it comes to individuals or subgroups of people or areas in the city. Yeah.
And this is where we're targeting with the AI for Healthy Cities initiative, right? There's a lot of evidence on individual risk factors driving specific outcomes. We know that higher income tends to lead to lower hypertension, or that certain diets lead to better heart health outcomes. But I think the key question is then how to prioritize, right? How do you prioritize investment in kind of diet and behavior change versus creating green spaces to promote physical activity?
And people want to do good. Decision makers, they want to do right decisions.
Yes.
but it's not very easy if you don't have the knowledge behind that or the data behind that.
Do you want to briefly comment about the discussions we had the last day and a half with our expert council to talk a little bit about the AI for Healthy Cities initiative, kind of the way that we are bringing together data on different determinants and how that might be helpful?
Well, of course, it might be helpful in a way that we could really turn our sight away from the so-called conventional kind of thinking to a more new kind of way to allocate resources, but of course also to justify whatever the city is doing. Because in Finland, people trust authorities and people trust the service system, but still they always think of where the tax money goes. And now we need sort of a more profound basis for that, and so that we can really honestly say that this is money worth used.
Well spent. Yes. Okay. Yeah. Thank you, Julia. Clinical context again, right? Like thinking about kind of data analytics. How do you kind of see where this could be headed? What are you using today in terms of tools that can leverage different data sources and help you with decision making? And where do you see opportunities evolving in a admittedly rapidly evolving space that is very hard to predict what comes kind of how quickly? But I think just your ideas around kind of the opportunity space.
At the moment, I must say we don't use much, and my understanding is actually in most healthcare systems, in the end, for clinical decision making by doctors. I'm not talking about the space, the community space that Juha was commenting on before. There's not that many truly AI-powered decision support tools that are being used, and I think. Even less so in the context of prevention. So there are some tools when it comes to treatment decisions, supporting, I mean, from my own area in infectious diseases, which antibiotics should I give in a specific infection, in a specific context for a specific patient. But again, that's very reactive. I mean, what I would like is to really understand better the risk that is attached to being a very specific child, in my case, with all of the different facets that influence that risk. And I think that goes back to what you were just saying before. Like, we know that, you know, if we target X, then we can slightly lower the risk for Y. But that's not what I'm talking about. What I'm talking about, and I'm going to use a slightly clinical term, and I apologize if that sounds rather strange, but it's sort of risk phenotypes. It's really understanding constellations of risk factors, how they influence each other. And I mean, one of our team was here. I think he's left, who is an AI specialist who is interested, and that for children is very relevant. For example, also in the context that Spring was talking about time differences in when risks are important. So if I had something that would help me to understand whether advising a certain family on diet now for this particular child at this moment in time is the right thing, or whether we should be thinking about educational settings and what support the family might need in that would really be fantastic. I mean, I think that would allow us to really provide care and preventive care on a completely different level.
Yeah. So Lukas already mentioned it in his opening remarks. We're embarking on a project here in Basel where childhood obesity is a key focus area. How is that project going to help? How do you see this evolve, both for improving children's health, but also potentially kind of impact on a larger population?
So I think that's always very interesting about focusing on children, right? Because when you're focusing on children, you're always focusing on families. And so I think one of the very simple ways, in a way, as simple, I mean in inverted commas, so just to be clear about it not being simple in real life, is that if you can actually identify these children at risk of childhood obesity, you will be identifying families who are at collective risk of poor cardiovascular health outcomes. And potentially by determining what you should be offering to these children, you will actually be offering relevant input to the whole family. So I think that is one of the ways that I hope, this project will become most relevant to the population that we serve, rather than just the children that I look after or my hospital looks after.
Yeah.
So I think. And I think it's one of the powerful things that you can do when you focus on children and young people. And I work a lot with colleagues in the Global South, and I think there it's absolutely clear to everyone that this is a very important route to take, because essentially you can influence the health of a whole population by focusing on this segment.
Yeah, very powerful and very good example of how interconnected these determinants are and the social drivers around a family, around a child. How important it is to think through how do these different determinants intersect and influence each other, and where do you actually start to kind of change behaviors to affect outcomes. We only have like 15, 18 minutes left. I want to open for questions from the audience, if you have any. I hope you took mental notes. We will come back to the panel, so I'll stop the questions a few minutes before we have to end, and then we do a lightning round with a key takeaway and wish for the future from each of the panel members. But let's go to the audience. Philip. Yeah. Oh, Gora first? Okay, Gora first.
And thanks for the wonderful discussion. Thanks, Peter. And you alluded to it, Professor Napier. Just wanted to understand, when we're talking about data, there's also a lot of black spots or blind spots in data. And to both of you, Professor Napier and Dr. Jolkkonen, I'm sure you would be finding those blind spots in the Finnish population as well. I know multiple islands where habitation is really sparse. How do you reconcile that? And because very often what we have seen is it is these blind spots where data is not coming out are also or in some ways excluded from all services, not just healthcare, but also education, development, and others. How do we reconcile that? And are there any real world examples of how we have used those gaps or blind spots for our interventions?
I think you can start if you want.
First of all, thanks for asking that. I think this follows really nicely, Julia, on your description of what would help you, right? Because, as you say, if this is a real example, so I'll give you a couple of real examples. So you're an HIV positive mother living in Houston, Texas, in a food desert, and you have a special needs child, and you don't have public transportation, right? Okay. So you got all that picture. These are all heterogeneous factors, which we previously, first of all, had no idea how to deal with. But I'm not making false promises for AI. But if you give it that data, it can churn out various potential models, right? But you have to have that data. And the problem for those vulnerable populations is the only way you're going to get that data is to go out and find it. You cannot have a focus group. You've got to say to the person of the focus group, who has your same problems, who's not here? And you got to go out and find what the tipping point is that gives that person agency to be there. And then potentially you can start to look back at that population. And I'll give you an example. So in Houston, Texas, just to follow on, when COVID-19, everyone knows this because that's one of my favorite examples that people that I've spoken with. When COVID-19 happened, people weren't taking their jab. They weren't taking their people. What do people assume? It's vaccine hesitancy, right? It's a low social capital state. We're sure that the governor was against it. Didn't want people wearing masks. That must be the cause, right? So the Department of Health said, well, we're going to give people, because they were thinking maybe we don't really understand what's happening in these invisible populations, right? But we're just going to give people $100 for the first jab and $50 for the second. And the numbers went up, and people assumed, well, maybe it's like people selling blood for money. Poor people do anything for money. No, so what they did instead was they polled these people on their way out, and they tried to characterize the prototype. And the prototype was a single mother with a child, right? Because she could use the $100 to get somebody to look after her kids so she could go and get the vaccine she wanted to get 3 weeks ago, right? So our assumptions about what drives that level of calamity coping, to use a phrase I used before, and our assumptions about what reduces or eliminates health agency are only assumptions unless we actually go out and find it.
it's a good question. From a data perspective, you're quite right. For instance, our health benefit analysis, of course, it's based on the data we have from those patients and clients who we have met. But then we need some other ways. Of course, we need to mobilize our, for instance, social workers to food lines and these kind of things. Schools and education is quite good because basically every kid goes to school, or if they don't come to school, we go and pick them up. And that's one way to find out those kids and those families with no services or need or lack of services they would need, and so-called blind spots. But when it comes to data, we don't actually have a population-based data, at least good enough to find the blind spots. That's why we also need some kind of modeling. We need some kind of ways to model on, assume those, for instance, subgroups of people or areas where would need to target some interventions without actually knowing from the data that this is the area, but we would have a model predicting that this could be the area we should focus on. Yeah. So well, it's an excellent question, because sometimes we forget we have an excellent data that is based or comes from somewhere, but we're lacking or missing some parts of it. Yeah.
Thank you. Philip?
Okay, my name is Philip Gerwil. I'm a former Novartis employee, and I'm very engaged, on digital health, AI for healthcare, and all that. So thank you very much for the great panel. And I have 2 points. The first one is getting, we're asking more and more granularity for this data. We need it. But who is going to provide the granularity? And I come back to your point, Julia, about, primary care. These guys are overloaded. They're even looking more at the screen than at the patient, and now we ask them to enter more data. So I see the challenge, and that was just one example, but I see the challenge there to get this granularity, because we need it, but you have overwhelmed healthcare professionals. We cannot continue to ask more and more data. And the second point is, let's put the elephant on the table. I'm fully behind, the preventive care topic. But for me, it's like recently I was in a panel about preventing wars. One of the key issues in wars is that you have a budget for defense, but there's no budget for peace. And here I think the same. Where is the budget for preventive care? We already have not enough money to treat the sick people. We are closing hospitals in some countries, and it's very different from country to country. So where is the money for preventive care, which I think is very important in our topic?
Might I just respond to the data collection? The money, that's not my business, so I'm going to leave it to someone else to answer that question. But I think that it goes back to the point that I was trying to make, and maybe I didn't make it well enough. But I think that if we could actually support people in accessing all the data that has already been collected in an appropriate way, we would have much more granular data without imposing on them more. At the moment, what happens is that I ask the same questions again that 3 or 4 people already before me asked of that family. And that is, of course, I completely agree with you, intensely frustrating for me as a healthcare provider. And I would balk at the prospect of having to collect even more. But I think I would be quite prepared to sort of add to an already rich data set if it was available to me. And it would also allow me to ask more intelligent questions. So I think healthcare providers could be engaged in this process, but I think they would need access to all the data that has been collected beforehand, before this consultation, in an intelligent manner. And at the moment, at least where I work, that isn't available.
Yeah. Juha, do you want to comment on that?
Yeah, short point. Very good questions. Of course, we've had a quite hectic discussion when we moved to EPIC, because EPIC is a highly structured documentation system. But now we are trying to use, or we are trying to pilot, a voice recognition kind of tool. So when a doctor or nurse or social worker meets the client, voice recognition finds out the words you need to document structurally. So I think I'm optimistic that within a few years, it's not the professional that needs to write down all the structured data, but we could also automatically do something about it. But it's a balance. It really is a balance between this kind of need for better data and the real life. Of course, that's true. And the other question was a bit more wider. So, but I like prevention, but I always ask for the evidence, because prevention is something that everyone can agree. You should do prevention. But when I ask, it's like you use a shotgun and shoot everywhere. So we really need to do what to do. We really don't know what to do. What is prevention that really is worth it, and what is not? This is a difficult question, because we can use all the money we want under prevention umbrella, but we can't be sure that it's money worth spent.
That goes back to the prioritization question, right?
Definitely, definitely.
Yes. And we don't, hang on, one more comment from David. Unfortunately, we don't have time for more questions. My apologies. But we can do this over the apéro after the event. Do you have a? Yes.
Maybe it folds into this one.
Yes, ask a question and then we'll fold it into David's comment. Okay, good.
Sorry. Yeah, a quick one. I have a question regarding data protection, which was referred to as difficult, and that's probably shared by many people working with the sensitive personal data. So I would like to turn around the question. Do you also see positive effects of data protection, sort of to enable sustainable development of all these tools, especially in the context of biomedical data, AI, and so on?
I'm just going to fold that into what I was going to
Excellent.
say.
Sounds good. Yes.
In any case, because a lot of this has to do with what you know and what your client knows, right? What they bring to the conversation. But the problem right now is what you were saying. I'm sorry I didn't get your name, but that everyone is time poor, right? So you can be very wealthy and still be as vulnerable for diabetes as somebody who doesn't have health care because you're commuting all the time and you just don't have time for anything. In Texas, this is exactly the case, which is why 2/3 of the population is obese or overweight, right? But the point is that and this gets back to a hobby horse that I've had for a very long time, since we did a Lancet Commission on Culture and Health in 2014, which is that if you go back to some of the early studies on clinical time, and you look at, they divided, and I'll just make this very quick because it's a longer story. They divided into the case history, the physical exam, and the tests, right? Where do you think the accurate diagnosis comes in? Anybody? It's the talking, the case history. Almost 83%, this goes back to the 1970s, of all accurate diagnoses were made by giving people the time to talk, right? So the AI, if the AI can provide you with not doing repetitive data, and we've been begging somebody to go out and look at this within the framework of all the things that have happened since 1976 when that study was done. Is it the same today? Could we actually be saving a lot of money given the isolation we're dealing with and the depression and the exclusion by giving people more clinical time with better information than we are by doing what we're doing, which is think we have to, we got to get from 12 minutes to 6 and maybe to 4, and maybe we're just going to give them an app and say goodbye and have a good day, right?
Okay, on that. Okay, quick one from Spring, and then we go to the lightning round.
Very, very quick on the data governance from a Global South perspective. We are sitting in a room full of people and in a world where people have trust in government. In many countries of the Global South, that trust in government does not exist, and suspicion about what the government is going to do with your data, despite the promises that are made, are very high. Interestingly, there's a lot of trust in Meta and et cetera, et cetera. So it depends on how you frame it, I guess, who's collecting the data for what purpose. But there is an opportunity to take advantage of the fact that municipalities will be the ones collecting data rather than this big federal government structure, because there is, again, a stronger trust in what the municipality can do for you. So there's an opportunity to be exploited there.
Thank you, Spring. Okay, lightning round. One key takeaway, one key wish for the future, thinking about this rich set of determinants. Maybe let's start with David and then walk through.
I think I should
You want to go last? Okay, Spring also just talked. Julia.
Okay, so I am actually going to come back to your data protection question, because I think that for me, the one key thing that we haven't maybe talked too much about now is engaging with patients or clients or customers. I don't mind what you call them. But I think the data protection space is the one space where this is really important. Because actually, when we talk to family representatives, what we think is data protection is not what they understand data protection to mean. I mean, and so I think that actually the more you talk about data, if you're not in a setting where there is clarity about, there's transparency, there's clarity about process, procedures, about what's going to happen to your data, and you have to engage with people about making this accessible to improve their care and the care of everyone else. I think this is where the legislature and the regulations and what people actually want and need doesn't match up. So in one of our studies that we have done in sub-Saharan Africa, people were saying, this consent form, that's not for me. That is not providing me protection. I don't know who it is for, but it's not for me. This is not what I think I need to be providing to feel that I have been fully engaged in making a decision about whether my child should be participating in this study. So I think that this is something that we haven't really managed to tackle yet.
Okay, thank you, Julia. Juha, your 1 minute takeaway?
Just one takeaway. I think AI is something that we should all be aware of much better than we are. I think when we go back here, I think all of us should do an ABC on AI, because we should know better the possibilities, but also the threats. And I think that's going to be revolutionary in the next few years. And I think we all talk about AI, but I don't know how many of you really know what AI means. What is done at the moment with AI and what's going to happen in 1, 2, or 3 years.
Yeah, very true. Thank you, Juha. Spring?
Just picking up on that a little bit, trust communities to be agents of their own health and to be sophisticated enough to understand the benefits of AI and engage with them in that fashion.
Thank you. And David?
Yeah, I think for me the takeaway is we all know that we've had it around long enough to realize that it's not going to solve everything, where it works and where it doesn't work. And where it doesn't work is really important, because considering that 90% of our health is made outside of the health sector, if we can't bring lived experience to the level of evidence, we're never going to get to those dark places where we have no data.
Thank you, David. On that note, thank you to my fabulous panel for a really rich discussion. I'm looking forward to continuing the discussion after the event over an apéro. Feel free to ask more questions, come find us, and many thanks.
Thank you.
Well done. Thank you. This was fabulous. Thank you. Please, David, you come first. Thank you. Really great job. Thank you again for a great job of our panelists. I would like to invite my two co-fireside chat colleagues. Yeah, I will sit in the middle. I learned, yes, here, and if you don't mind. So it is my biggest pleasure to introduce my two fireside chats colleagues, panelists, whatever. On my right is Professor Michelle Williams, who is the former dean of the Harvard School of Public Health. And on my left is Professor Srinath Reddy, who's the past president of the Public Health Foundation India and the past president of the World Heart Federation. So welcome. Welcome also to you. And we already had the pleasure to meet during these past 2 days and benefit from your generous expertise sharing for our program, AI for Healthy Cities. When we heard from our previous panelists how important it is to really consider what we can do with data and avoid that we create more work for our colleagues, but also that the AI part is not going to be a golden bullet answer for everything. I still want to bring it back to the fact that we need to combine a quantitative analysis with this qualitative analysis. It's so important to not forget the invisible populations, David, that we make sure we account for these black gaps in the data, but also that we look at the role a public-private partnership like this one, AI for Healthy Cities, like you said, Lukas, working together between city authorities, research partners, and the private sector like us to develop, in the end, a new paradigm of population health, because that's what we need. Juha, you say it beautifully. We need a new model of how we will address population health and improve them while we narrow health inequities. So let's explore how we can do that, how we can make sure our initiative AI for Healthy Cities reaches that, and not only for the cities where we are rolling it out, New York, Singapore, Helsinki, Basel, but also for the rest of the world. Because we don't do this for the research. I forgot maybe to say that in the introduction, but our goal is really to translate the data insights into reality, into action, and influence policy that it comes to that transformation from healthcare to health, that our health systems become proactive, predictive, and ultimately preventive, that they keep their people healthy. So in that sense, Michelle, I'm so thrilled you are my co-chair of the Global Expert Council. What motivates you to join us in this endeavor?
That's a great question, and I have to say it's the power of partnership and collaboration. So I'm a lifetime academic, and I spent most of my career writing papers and creating knowledge and teaching people how to do research. But the real impact comes from unlocking that knowledge and putting it into translational spaces. So when you invited me to participate, I thought that this is a way to interject the academic principles into a public-private partnership. Mm-hmm. I like to talk about it as public-private academic partnerships, where this collaboration not only leads to impact, it also brings transformational change in demonstrating what we learn, sharing it, and putting it back out into systems where we can bring to scale the things that we have. I want to have impact. I think every academic wants to have impact, but we can't do it alone. We have to work with state actors who have the mandate, and we have to work with private sector partners who have the know-how and the wherewithal and some of the credibility for being out in the world solving real problems in real time.
Thank you so much. It's a very beautiful description of a public-private academic partnership. And in your, with all your expertise in population health, can you give us an example or two about areas where you saw that data made a real difference in policymaking, where there was an enlightened leader who took the decision to use data and make his decisions or her decisions based on evidence instead of opinions, which we are more used to see in the political space.
Yeah, I'm a reproductive and perinatal epidemiologist, and I just listened to the professor talk about research in pediatrics, and I'm going to say one of the best examples that I know where data informed massive investments was in early child development investments. Mm-hmm. So in the United States, when Julius Richmond said, we need to invest in early childhood development, and the government did this. And then years later, the data showed that the return on investments for every dollar spent on early child development, the returns was 16 times greater. Where in anywhere in the economic space do you see that kind of return? That's an example in the space of childhood development. Mm-hmm. And what we in public health have not always done is bring forward the data not only on the health outcomes that an intervention can bring about, but also the economic impact that the investment can have. Yes, prevention costs a lot of money, but have we calculated the returns on that investment? Have we calculated the lost economic productivity for absenteeism and presentism? So I would say we have to transform the way we think about investments in prevention by calculating the whole spectrum of where the benefits are accrued.
This is exactly what we hope to achieve also with AI for Healthy Cities, Michelle? So we want to develop with our data insights a model, a simulation model that every decision maker we speak to is asking us, how can I know whether when I invest my $200,000 in this intervention, what is going to be my health impact and the overall cost of that intervention? But they also need to know what is going to be the cost if I don't do that intervention. And this is what we hope to achieve with our AI for Healthy Cities. But Srinath, with your last book on Pulse to Planet, the long lifeline of human health, you perfectly describe why disease is not a single entity. Disease is a combination of factors of social, economic, cultural, environmental factors, everything together. We need to look at people in a holistic way and not just as a disease related to one organ of our body. So can you tell us a bit about your experience, where that comes from? How did you see that, as you are the population health leader in the most populous country in the world? So can you tell us a bit about your experience there?
And I transitioned from being a clinical cardiologist and a researcher in cardiovascular epidemiology, looking at risk factors of how health transitions are taking place in low and middle income countries, especially my own, to looking at public health dimensions. In fact, when people ask me how I transitioned from a very typical clinical cardiologist role to public health, I see that not as separate worlds, but as a continuum. If clinical medicine delivers health in retail, public health delivers health in wholesale. But then we also must recognize there are multiple determinants which have already been discussed in the previous session. At the level of the individual, health is determined by an interplay of biology, beliefs, and behaviors. A little more upstream, at the level of the family and the community, you have also other determinants like cultural perceptions, priorities that are accorded as to how the money in the family is spent, whether on tobacco or alcohol or on nutritious food for children. Then pathways of access and affordability. Do you have smoke-free public places? Do you have areas for safe and pleasurable physical activity, or even for cycling, protected cycling lanes and pedestrian pathways? All these come in. But even more upstream, at the national and global level, you have the stage and speed of development, distributional issues of equity in multiple dimensions, and the dynamics of demand and supply at the level of trade, as we have seen during the COVID epidemic, and the access or lack of access to vaccines. So when we are trying to understand all of these dynamics and how they ultimately impact on human health, we need clarity about that interplay, and we must also understand how best we can influence that. We must not be deterred by what appears to be complexity, but we must find solutions which are both focused as well as act at a higher level on multiple determinants so that they can synergistically support health across the life course. And we know that these determinants act from the beginning of life, from preconception to the end of life to palliative care. So throughout the life course, we need to understand how these dynamics occur so that we can try and intervene and influence them to promote, protect, and restore health.
May I just add a point?
Of course.
This is such a beautiful response. And what it does is it highlights why it's important when we hear the term health in all policies. What you heard is labor and trade decisions, agricultural decisions, urban planning and urban design decisions, all play a very important role in health and wellness of populations. But we don't typically think about it that way, right? And that's a mistake that can be addressed if we really harness the data across all of these sectors and be very smart about making the case that all agencies have a role to play in population health.
And Michelle, basically I would also like to say that when we talk about health in all policies, it also requires an all-of-society response. Yes. And both in terms of ensuring that policies are actually responding to these needs, that policies are effectively implemented, and with adequate public participation as well, and also monitored in terms of their effectiveness of implementation. So public-private partnerships, as Ann said, are very critical. Frequently, they've been misinterpreted as a transactional relationship between the public sector and the private sector. But I would like to redefine public-private partnership as partnership for a public purpose. Define the public purpose, and then say how it's going to be delivered by a variety of partnerships. It could be between the public sector and the private sector, could be between two private sector entities, could be between government and NGOs, could be between two NGOs, but all these partnerships will have to emerge in order to influence the dynamics at the societal level, ultimately to protect the individual. And I think this partnerships for public purpose is going to be critical as we move along to try and influence these determinants, because we have seen, as has rightly been pointed out, even in the COVID pandemic, that solidarity that was required at the global level was missing. Yeah. And even at the national level, if you want universal health coverage to succeed, it has to depend on social solidarity. So I think this partnership has to be built at multiple levels between multiple agencies, and ultimately we'll have to see people-partnered public health and digitally enabled decentralized decision-making at a community level.
And if I may add, because our time is already up, it also has to include data-driven decision-making, right?
Yeah,
because that's the goal of AI for Healthy Cities, our whole dialogue. We want to equip the decision-makers with the right information to make those choices. Which policy should we influence first? The food or the transport, or is it the urban planning? Whatever it is, we need to document and to base it on existing data so that we can help more governments moving forward in the right direction. And I hope, as Spring was pointing out on the rapid urbanization and specifically in the South and the low and middle income settings, I hope those settings will be able to leapfrog with the data insights that the data-rich cities will be providing to leapfrog some of these decisions and use the models we develop in their settings to get to the better outcomes.
May I make a brief comment about reflecting on one of the questions that was asked in the last panel? What about missing data? Yeah. How much are we hampered? How are we going to determine? I think throughout the history of public health, and to some extent even in clinical medicine, we have always learned to cope with uncertainty. Yeah. Absolute certainty is only the privilege of the divinity and like-minded clinicians. But I think what we really must understand is that basically, if the perfect is not possible, perfect the possible. Use the data available to make the best possible analysis. And then try and set right systems that you can collect the missing pieces and then improve the systems progressively, rather than give up the effort in the first place.
That is what we all agree with, I am sure. A warm applause for my two speakers here. This was a fantastic, too short. Thank you so much. I'm sure you will get a lot of questions in the apéro. But it only rests me to say a very big thank you to all of our speakers, and let's join together again in a warm applause for all of them, the panelists from before and our two people here. I also want to thank all of my team of the Novartis Foundation who has been organizing this event. A very big applause for all of them. It was perfect, flawless, and all of you for your engaged participation in this dialogue. I hope we can count on your continued engagement in the future, as we will come back with more results in the near future, and also during the apéro, of course, because we will all be there with you and can continue the conversation. But thank you again and have a very nice evening. Please join us here next door.